and thank you for being here today. After 2 years of being virtual, it is a pleasure to see everyone in person, being here at Fact versus Fiction, supporting the Dubin Breast Center. So thank you all for coming. My name is Eva-Andersson-Dubin, and I'm the founder of the Dubin Breast Center. Oh, thank you. This afternoon, we have an incredible panel, and we will have an engaging Q&A, so please be ready with all your questions. Just a little bit about the center. We opened the center in 2011, and the center continues to grow, even though we had COVID that took us for a little spin. We continue to grow, and we continue to look for space. Today, we see an average of 180 to 200 patients a day. And since the day we opened, we have seen 380,000 patient visits. Thank you, thank you. I'm so thankful to everyone that works at the center, my partner in crime, Dr. Elisa Port, and to all of you for supporting the center. So thank you again. So I'm now pleased to introduce our patient speaker. We had two, but we lost one who is home with COVID, unfortunately. But we are very happy to have Julie McAllister here. Julie is a DBC patient, DBC Dubin Breast Center patient, and a member of the Dubin Breast Center Advisory Board. Her story is so inspirational, and we are, again, so grateful to have her here today to share her journey. So please help me to welcome Julie McAllister.
Hello, my name is Julie. I was diagnosed with a very rare type of triple-negative breast cancer when I was 36 years old, almost 6 years ago. I was in complete shock. I was young, very healthy, active, a mother of 2 children. My youngest was just 6 months at the time. There wasn't any history of breast cancer in my family. Breast cancer wasn't even a remote part of my reality. It was something that I thought happened to other people, and I felt very badly for those people. 2 weeks after my diagnosis, I learned that I was BRCA1 positive. I was in double shock, in a depression. And I truly didn't know if and how I was going to survive. I kept thinking about my kids and how much of their life I was going to be around for. Not to mention that my husband and I wanted more children. My OBGYN, Dr. Shari Brasner, immediately took the reins in my diagnosis and arranged for me to have all the necessary imaging and scheduled a consultation with Dr. Port within days of my diagnosis. I left that first meeting with an enormous amount of confidence in Dr. Port, her abilities, her diagnosis, and treatment plan. I did, however, get a second opinion, as many people do, but eventually decided to have my treatment and surgeries at Mount Sinai. Upon deciding on Mount Sinai, Dr. Port introduced me to Dr. Iriye, who became my oncologist. Dr. Iriye was the best and felt like my lifeline during my treatment. She was straightforward, incredibly smart, kind, never making me feel like any of my questions and or fears were silly or unwarranted. And she helped me find a clinical trial to participate in once my standard treatment was complete. I spent a lot of time at Mount Sinai. I underwent countless surgeries, 5 months of chemotherapy, 6 weeks of radiation, and years of ongoing surveillance. Throughout all that time, I always felt like I was in the best hands and had the best doctors and nurses looking after me. I never felt like a generic cancer patient or a statistic. The nurses and staff were extremely warm and knowledgeable. The treatment rooms were comfortable, and I never felt alone. Cancer isn't something that I would wish on anybody. It crushes you physically and mentally. It changes you, puts a fear in you that you never knew existed, and alters the way you think and worry for the rest of your life. But knowing that there are places like the Dubin Breast Center, with doctors like the ones I was fortunate enough to call mine, that can and will help treat and cure your cancer is incredible. I am forever grateful for the treatment and care that I received from Dr. Port, Dr. Iriye, and all the nurses and staff at Dubin. And my silver lining to my cancer diagnosis is my daughter, Catherine. Doctors Port, Uri, and Brasner helped guide my husband and me last year when we decided that we wanted to try to have another child. Almost 4 months ago, I delivered my daughter, Catherine, at Mount Sinai, just 2 floors above the Dubin Breast Center. Thank you.
Thank you, Julie. I always need to take a second after I hear our patient speakers, but thank you, Julie. I think I can speak for all of us when I say that your journey has been extraordinary, and your story exemplifies what inspires all of us at the Dubin Breast Center each and every day to push the boundaries of what's possible with breast health. Seeing our amazing patients and their survivor stories and them surviving and thriving is our greatest motivator for sure. And so thank you to you and to Brendan and to your family for entrusting us with your care. It means the world to us. And thank you to all of you today for joining us. I am Elisa Port. I'm the director of the Dubin Breast Center, and it is, gosh, just an understatement to say how happy I am that we can be here all together in person. Amazing. I really loved wearing my sweatpants and my sweatpants, scrubs. 2 years, right? 2 years, just cycled between those two. But I was kind of ready to get back into the party dress. I definitely could leave the heels behind, and I'm so happy that the podium is opaque. You can't see because they'll come off before the talk is over. But despite the heels, it's truly wonderful to be here and to see so many both familiar and new faces. So thank you all for being here. As you all know, fact versus fiction is a really important opportunity for our experts to share important, and more important to me, actionable knowledge with our community. It's also a really important source of support that makes our work possible. And I want to thank all of you for your generosity. Philanthropy is really the backbone of what we do at the Dubin Breast Center because it allows us to provide the best care to every single patient, regardless of her ability to pay. And in particular, I want to do a shout out and thank our incredible advisory board. You all are our biggest supporters and our biggest champions and advocates. So thank you all for being there through thick and thin. Of course, I want to thank my partner in all this, the Lucy to my Ethel, or as we always say, we're the dog and pony show, so the pony to my dog, right? I'm always the dog. Okay. When Eva and I set out to create a safe haven for women with breast cancer over a decade ago, but that would also deliver the highest, most cutting-edge level of care, I could never have imagined how large this center would become. Our growth has really only been possible with the Dubins and with their philanthropy and leadership as we make our plans to expand. So, Eva, I'm eternally grateful for your steadfast guidance and vision and friendship. Thank you for everything. I want to just talk a little bit about the pandemic because we overcame so many challenges in that area. We're not going to address the specifics of COVID today, but I will say that the pandemic really did cast a spotlight on a critically important challenge that all of us at the center have faced all along and are completely committed to combating, which is disparities in healthcare, which became really magnified during the pandemic and patient access to care. What do you do when you have to get your chemo and your child is at home, homeschooled, and you have no babysitter, and you also don't want to take the subway because of exposure, but you really can't afford a taxi or an Uber? So these are some of the things that COVID really shined a light on for many of our patients. And we're incredibly proud of serving one of the most diverse patient populations in the world. Despite the impact of the pandemic, though, cancer, as you all know, did not stop and does not wait. And that's what makes the fact versus fiction discussion so important. After being apart for 3 years, we did do this virtually a couple years ago, but it's no substitute for what we're doing today. We never stopped thinking about the numerous questions that we wanted to answer for all of you in breast cancer and in women's health. And we never stopped wanting to bring you all the latest information, which is so important. We're excited to share more about our efforts in progress and research today, and to bring the expertise of our incredibly multifaceted panel, my dear colleagues and friends here, to bear on your most pressing questions. So, most important, enjoy your meal. This is a working lunch, so please don't hesitate to eat while we're asking questions. And I really want to get started. What we're going to do is I'm going to introduce each panelist, and I'm going to introduce them with an opening question. And just understand at the end, after one round of questions, we'll open it up. If you are too shy to take the mic, please don't be. But if you are, there's also index cards that you can pass to people, and they'll bring them up, and we'll read off your question. And here's the thing, okay? These shouldn't be personal questions like my case this and my case that. And we also know when you say, I have this friend I'm asking for, not me, I have this friend. So try and keep it general, things that everybody wants to hear about, which would be terrific. So let's start with our first question. As you entered, we asked you a survey question, and that's going to kick it off. And it's really to open the conversation and to underscore how much uncertainty there is out there regarding some very important and very basic information. So the first question is to Dr. David Anderson. Dr. David Anderson is a board-certified and fellowship-trained breast surgical oncologist who practices at the Dubin Breast Center. He joined us approximately 1 year ago from the University of Pennsylvania, having built a huge practice there. And prior to that, he was at Memorial Sloan Kettering Cancer Center, where he was a fellow. So we started the day by asking our survey question, okay? The survey question was, more than 50% of breast cancer patients have a family history of breast cancer. Fact or fiction? So before you answer, David, here's what you guys answered, okay? And it's interesting, because it's pretty, not exactly split down the middle, but 40% said this is true, okay, and 60% said this is not true. So David, what's our answer? Take it away.
So, is this on? The answer is this is fiction. So this is a very common misperception that I actually see in the office quite often. And a lot of women come in with a newly diagnosed breast cancer, and they say, why did this happen to me? I don't have any family history. This is a shock. This is a surprise. And the truth is, the fact of this is that 80 to 90% of all patients with breast cancer have no family history. So again, 80 to 90% have no family history of breast cancer, which is it's a revelation for a lot of patients. Because it's not necessarily the family history that's your biggest risk factor. It's actually your gender and your age. And that's very important, because a lot of people may have misperceptions about when they need to be screened and things like that. So just because you don't have a first-degree relative with breast cancer or, say, ovarian cancer, doesn't mean that you shouldn't follow screening guidelines and things like that. So a very important point. To take it one step farther, there are women who have genetic predispositions to breast cancer. They have genetic mutations that cause their breast cancer. And in fact, of all breast cancer patients, only 5 to 10% of them actually have one of these genes. So the majority of patients have no genetic predisposition and have no family history.
Okay, that got things started. Amazing. And I can tell from the audience response that we've already learned something incredibly important and new. And remember, I view all of you in the audience as our emissaries to take this information out to the wider community. Okay, our next panelist, Dr. Anna Barbieri. Dr. Barbieri is a double board certified gynecologist and integrative medicine physician in practice in New York City. She's also a North American Menopause Society certified practitioner. So Dr. Barbieri, as everyone's waving, they're fanning themselves, right? So Dr. Barbieri, You know, we want to know more about what non-hormonal options are there to manage menopausal symptoms in women both with and without breast cancer. Give us a couple of options. And the reason we ask this is because, of course, all women, regardless of breast cancer history, can experience menopausal symptoms. But our breast cancer patients may be at a disadvantage related to the hormonal options, particularly if their cancer was hormonally fed. So let's talk about what the non-hormonal options are for addressing menopausal symptoms.
Sure, and first of all, thank you so much for having me here. I want to tell everyone that this panel has allowed me to score major brownie points with my mother-in-law, who is a Dubin breast cancer patient who could not be here today, but she proudly displays her invitation with my picture in it, so thank you for that. When it comes to menopause, you know, when we speak about menopause symptoms, it can mean so many different things because there are actually about 34 different symptoms of menopause. And when it comes to non-hormonal treatments, often we need to figure out which symptoms we're trying to manage and choose the right pathway to that. As a gynecologist, as an integrative medicine physician, I always talk to my patients about the basics of health, which are going to be nutrition, movement, sleep, and stress reduction. But it's such a wide topic that we kind of have to leave that aside for today. I'm going to focus maybe on hot flashes and night sweats right now because these are so common and we get so many questions about that. There are actually a number of medications that can be used that are both FDA approved, including an option that is FDA approved for management of hot flashes and night sweats, and some medications in that same family. These are going to be certain antidepressants that are used very commonly for management of these symptoms. There's a number of other medications, as well as some therapies and even supplements that can be tried. There's a product that includes as the active ingredient something called the Swedish flower pollen that has been subjected to some studies and has been shown effective in reduction of these symptoms. That's non-hormonal in nature. And there are also some phytoestrogens that have been studied as well. We try to limit the use of those in women at high risk for breast cancer and with a diagnosis of breast cancer. The other therapy that's employed pretty widely is also acupuncture, with some promising data in women both with breast cancer and without for these.
Which is safe for both, right?
Which is safe for both, yes.
Wonderful. Great. And I'm sure we'll be hearing some more questions about the specifics later. Moving on to Dr. Jeffrey Mechanic. For those of you who have been to a fact versus fiction lunch before, you will know Dr. Mechanic is our secret weapon, who we always call upon to include because he is a world-renowned endocrinologist and has authored more than 300 publications on endocrinology, metabolism, and nutrition, and co-edited and co-authored 9 books on these subjects. So Dr. Mechanic, the question that we always get, does sugar feed breast cancer or any cancer? And here's the one, we're going to take it a step further today. Among the different types of sugar, okay, is there a hierarchy of healthiness? I had a cup of tea last night. I put a spoonful of honey in it, thinking so much better for me than that Domino's white refined sugar. But we have Domino's sugar, we have sugar in the raw, we have honey, we have agave. Tell us a little bit, is it just marketing and packaging, or does it really all do the same thing?
Thanks, Lisa. It's really a pleasure to be here again. So, does sugar feed cancer? Simple question, a little bit complicated answer. All cells, all cancer cells and all biological cells, they require sugar, the basic building blocks for carbohydrate. So you can easily see how scientists over the years have put together a hypothesis that the more sugar a human being would consume, the more it might affect growth of cancer cells. So that was a hypothesis. There have been a fair number of animal studies, and in fact, studies that started off in Russia and then migrated here to researchers in California and other places studied hydrazine sulfate, which was an essential ingredient for rocket fuel. And it turned out that hydrazine inhibited one of the enzymes where the liver would make sugar. And by inhibiting that enzyme, sugar levels in the animals would go down. And in these particular studies, it was associated with some slowing of cancer cell growth. That was sort of hopped on by people in the alternative care world who spread the concept that sugar fed cancer cells, and then you had a lot of fad diets where people were avoiding sugar, and it was baked into some supplements that did that. Turns out, there are no human studies that can defend or corroborate that theory. Even the hydrazine studies eventually were debunked. Your body will maintain a constant sugar level, a constant level of glucose, and that's in your blood. We have hormones that maintain a safe range of glucose. So the cancer cells, even if you eat a high sugar meal, the cancer cells are really not exposed to increased amounts of sugar. So really the answer is no. However, should you be consuming a diet where there's a lot of sugar? And this gets to the second question. Are there different kinds of sugar, the basic building blocks? And as it turns out, like with any other chronic condition, with cancer, with breast cancer, you have the responsibility to adopt a healthy lifestyle. And that healthy lifestyle means healthy eating. You need to have a certain amount of fiber. You need to have foods that are natural, that are whole foods, minimize the amount of processing for those foods. So it turns out that if you eat, say, fruit, right, and fruit is high in fructose, sugar, and you go, well, if I eat a lot of fructose, is that going to be bad for the cancer, et cetera? The fruit in its natural form has a lot of fiber. And the absorption of that fructose is blunted, so you don't really get those peaks. So now what we do in the answer to this question is we move on to what is a healthy eating pattern, not only for everybody, but for those with cancer. The Institute of Medicine and the government has dietary guidelines for Americans put out that 5 to 7 servings a day of fresh fruits and vegetables, plants, legumes, et cetera, would be healthy. We actually push it up to 7 to 10 servings a day, and that would be a serving that fits in the palm of your hand. Staying away so much from saturated fat, though that's also another contentious issue, but to have healthy oils, extra virgin, olive oil, et cetera, for your fats, to have protein, lean meats that don't have a lot of fat content. But really, it's a plant-based diet. That doesn't mean vegetarian, it doesn't mean vegan. It means the majority of the foods that you consume, that you go to the grocery store when you buy, should be plants. Legumes should be an essential part of it. In other parts of the world, they call them pulses, and those are any plant that's in a pod. So that's peas and beans and lentils. And 2 servings a day, when you study populations around the world, are associated with decreased chronic disease, including cancer. Can you have sweets and treats? Of course, but they should be judicious and sparing. As far as the different kinds of sugar, honey and agave nectar, because of their viscosity, they're thicker. They don't really raise the blood sugar as much, and there are some health benefits. But artificial sweeteners, though in controlled studies, if you actually control for the amount of sugar versus an artificial sweetener, you may lose weight. In free living studies, when you have an artificial sweetener early in the day, so think about the 60s when hanging out by the pool and you had your can of Tab, right? When you consume artificial sweeteners, because they interact with taste receptors, not just in the mouth, but in the intestine, it actually drives appetite. Those people will consume more calories for the rest of the day. So actually, that would be the reason to argue against the consumption of artificial sweeteners. I'll stop there.
Amazing, clearly thought-provoking, and I'm suspecting it's time to give up my Splenda. So, habit. Okay. The next person on our panel Dr. Cardinale Smith is a professor of medicine at the Icahn School of Medicine at Mount Sinai and chief quality officer for cancer services at the Mount Sinai Tisch Cancer Center. She is a grant-funded researcher whose work focuses on evaluating treatment disparities and interventions, focusing on eliminating barriers to high-quality cancer care delivery among racial and ethnic minorities. So, Dr. Smith, give us some examples of health inequities and disparities in breast cancer for women of color, and what are the factors that lead to those disparities?
So, hello everyone, thank you. I don't know, can I extrapolate that chocolate comes from a bean and therefore it's
Over 70%. Good over 70%.
It's funny, I feel like we all share that story.
We should know, right?
Yeah.
I'm learning with you. So, hello. You know, I think we know that racial and ethnic disparities exist in cancer care, and particularly when we think about breast cancer, it is complex, right? So you may have heard folks say that, you know, race, ethnicity is a social construct, right? Because we made it up, right? We decided to have these categories of who's Black, who's white, who's Asian, et cetera. But yet we know that that does factor into how patients are able to receive care. And so if we think about the cancer continuum, the trajectory, there is risk reduction strategies, screening, diagnosis, treatment, and survivorship care or end-of-life care for those who might be diagnosed with incurable breast cancer. And along that entire trajectory, we see areas of inequity. If we start with just risk, right, we know that women who have menses early on are at a higher risk of developing breast cancer. And that tends to be more associated with women of color. If we think about when women give birth, typically, and this is all generalities, typically more middle, upper class women are more likely to have children later on in life, right, 30s and above. And we know that while those women can still get breast cancer, they are more likely to get the better prognosis breast cancer because there are different types of breast cancer. Whereas in general, women who tend to be women of color are more likely to have children early on in age, which is less protective. Breastfeeding is also protective, and women of color tend to breastfeed less. So when we think about risks in general, that exists. When we talk about genetic screening, as has been mentioned, you know, not enough women of color have undergone genetic testing for us to be able to really be able to associate some of these genes, we call them of undetermined significance, because we don't have enough of them in the population yet to tell us if someone is at risk, if they have it or not. And, you know, I think this gets to something that we talk a lot about most recently with COVID, which is the social determinants of health, right? So these are our environmental, population-based factors that impact us. So it's our ability to obtain food. It's our ability to obtain housing, our ability to obtain transportation, to have insurance, but not just have insurance, but have high quality insurance that allows us to access high quality healthcare. When we think about treatment specifically, and my colleague over here will probably touch much more about this, but when we think about women getting breast cancer treatment, these are all women who, specifically women on clinical trials, these are all women who are accessing the same level of care, right? They've made it to the same place, they can go on the trial, they're getting what we would consider to be standard treatment. And yet we still see that women of color, and in particular Black women, are not responding to those treatments at the same rate that white women are, meaning they are dying more, their cancer's coming back more, or they're experiencing more complications related to that treatment. And the question then becomes why? And this gets back to how we identify people from race. We know that biologically, right, people have mixed a lot as they've moved around the world and as we have gotten to where we are now. And there is something biologically that is different. And we're just starting to understand that. So for example, in breast cancer treatment, right, we have a risk score that's done for some breast cancer types. And that tells us whether or not someone would benefit from receipt of chemotherapy. But those trials were done on majority white women. And so the information that we have for those trials are not necessarily generalizable to non-white women. And yet that is what we use to treat everyone. And that is where we're starting to see some of these inequities. I could go on, but what I would end with is that one of the things that I am so appreciative for being able to work at Mount Sinai, and Dubin in particular, is that Dubin all, as Elisa mentioned earlier, all women, regardless of ability to pay and insurance type, are able to receive their care at Dubin, right? And we know from work that she and others have done that, once folks are in the door, we're able to get you the care you need and get you the treatment you need when you need it, so that your outcomes are as equivalent as they can be. But we got to get people in the door, right? The second is that what COVID has shown us, some of these inequities that have played out, particularly when we think about healthcare, is what we call this digital divide, right? So that we know there are people who have access to internet, they have access to broadband data, they were able to do video visits, right? They didn't necessarily have to get on the train and put themselves at risk to see their healthcare provider. And yet, even when we looked at our own internal data, we saw that patients of color were much more likely to come to in-person visits because they didn't have access to that digital platform so that they could do video visits. We've, in the year since we've started a pilot program to engage all of our patients, and particularly our patients of color, on being able to get on My Chart, which is the platform or patient portal that we use, we've been able to go from a rate of about 60% of Black women enrolled to 80%. We've been able to go from 55% of Hispanic women to 75%. And we're not going to stop. We want to get as close to 100% as we can so that we're really providing as much care as we can that's equitable. Lastly, we have very robust social work and care coordination within Dubin. And that really, when we talk about the social determinants of health and really being able to understand what patients need, we've instituted what we call a social determinant of health screener, so that at every second visit, we're able to do a screen and we understand what your needs are, and we can tailor that coordination and navigation to needs. Thank you.
I think this really underscores, the absolute and ultimate commitment of Dubin to leveling the playing field. And also, just so you all know, the reason we have, to Dr. Smith's point, the robust social work service, that is all paid for by philanthropy, okay? So it's what your support for us has done, okay? So moving on, Dr. Sperano is our new chief of the Division of Hematology and Oncology, who was recruited 1 year ago as a breast medical oncologist. His research is world-renowned, and he developed, for those of you for personal experience or with family or friends who've had breast cancer, he developed the Oncotype test to help determine need for chemotherapy. So I'm thrilled to have him in the Dubin Breast Center now as a colleague for my patients. And given that, I want his opening question to be, so since we last met 3-4 years ago, and what continues to be the trend is we are giving 20 to 30% less chemotherapy than ever before, and yet the outcomes have remained, if not the same, better. So we're sparing all of these women chemotherapy. How are we doing that?
Well, the Oncotype test is part of why we're able to do that. The test became available in 2005, and just to be clear, I wasn't involved in developing the test, but I was a clinician who was in the clinic and was excited by the availability of the test to help make informed decisions. It really was one of the first tests that we had in the era of precision medicine that could help us better guide treatment decisions in this case, for patients with women with early breast cancer, estrogen receptor positive, HER2 negative, node negative breast cancer that accounts for about 1/2 of all cancer cases in the US and 8% of all cancers in the United States. And most of those patients, women and men, a few men at the time, were routinely being advised to receive adjuvant chemotherapy, meaning chemotherapy given after surgery. Even though the lymph nodes are negative, the tumor was relatively small, because we knew from prior clinical trials that chemotherapy helped reduce the risk of recurrence by, on average, of about 1/3. So if your underlying risk of recurrence, what that means for an individual patient was that if your underlying risk of recurrence was about 30%, when I say recurrence, I mean recurrence in other parts of the body at some point in the future that was somewhat unpredictable, we knew that chemotherapy can reduce that to about 20%. But if your underlying risk of recurrence, say, was only 6%, then your absolute benefit from chemotherapy was only 2%, so very, very big difference. And we really couldn't identify patients who didn't derive some benefit from chemotherapy. And the Oncotype test arrived just at about the same time that an expert panel convened by the National Institute of Health and the National Cancer Institute recommended that all women, irrespective of their risk, even those who had the lowest risk disease, be either recommended or considered to have chemotherapy. Well, the Oncotype test became available, and it became very clear from the types of studies that were done, and as the test was now used in practice, that it can identify people who had either a very low risk that clearly didn't need chemotherapy, or a very high risk who clearly did need chemotherapy. But we were finding in clinicians like myself in clinical practice found that about 2/3 of the patients, the score was not really helpful. And we were still in a situation of what we call equipoise. We really weren't sure what the right answer was. And in that circumstance, what you normally do is you treat everyone to be cautious, especially women who were younger and healthier. So we designed the TAILOR-X trial. When I say we, I mean a team of many people involving many layers of scientific review, funded by the National Cancer Institute, global trial done in 4 continents, involved over 10,000 women, where they met the standard criteria for recommending or considering chemotherapy, but they had the treatment either assigned or randomized based on the chemotherapy. So if their score was low, they were assigned to receive endocrine therapy alone. If the score was high, they were assigned to receive chemo plus endocrine therapy. And if the score was in the mid-range, which was true for about 6,700 women on the trial, they were randomized to chemotherapy, endocrine therapy, or not. Now, imagine yourself in that situation and being willing to do that. So I think we have a lot to owe, those women who participated in the trial. And so what we found was first results we started the trial in 2006, accrued about 10,000 patients in 2010, and we had to wait until 2015 to see our first results that the women who had the lowest score, which was about 17% of women who participated in the trial, they had a less than 1% risk of recurrence at 5 years with just endocrine therapy alone. So it was very clear that that was sufficient. So that was a big advance. The next results became available in 2018 when we found out from the randomized group that which again accounted for about 2/3 of the patients, that there was clearly no chemotherapy benefit. Now remember, this is a group of women who we would generally recommend to receive chemotherapy. So it took about 13 years, actually, between the time the first test it became available until we had the information from that study. And we now have information from another study indicating that you could even spare chemotherapy in women with up to 3 positive axillary nodes based on this test. So we actually are now sparing about 70% of women the use of chemotherapy, who would have, probably higher now, based on the most recent study, who would have been recommended to receive chemotherapy in the past. But that's not the end of the story. We went on to develop a test that I think it's a very valuable test, but it's also important to capture all of the other pieces of information, the age, the tumor size, the grade of the tumor. And we've developed a new tool called RS-CLIN, where you can rate and personalize your risk of recurrence based on the recurrence score and the other factors, which gives you more precise information about the risk of recurrence for you as an individual with your specific characteristics and recurrence score, and also the benefit from chemotherapy.
I mean, this is so incredible to hear about. I know this catches a lot of people as new information. I think one of the points it underscores is, of course, one of our biggest pushes, which you'll probably hear about a little bit, is developing newer treatments, more treatments, better treatments, et cetera. A lot of what we also do in breast cancer is figure out ways that we can dial it back without compromising any outcome. Any patient that can be spared chemotherapy, spared radiation, do a smaller surgery instead of a bigger surgery if she wants. These are also really big wins in breast cancer that have happened all along. So now comes the fun part. We are opening up to comments. We do have a microphone that we can pass around, or you can just stand up if you have a very loud voice, or you can come up here and share my microphone. Any questions from the audience? Question in the back.
Yes, hi. First and foremost, thank you so much. I'm beyond grateful for all of the incredible work that you do. My question is twofold, and it's primarily to both Dr. Area and Dr. McKinnon with regards to nutrition. As women in menopause, many of us lean on a little too much alcohol consumption.
Not rosé, not rosé.
You might be feeling, what role do you feel alcohol consumption plays in increased cancers? And the other question I had is related to toxicity in our environment and what role you feel that plays as well. Most importantly, personal care products for women, which is a very unregulated market. And there are things that we are putting on our skin and consuming on an everyday basis, and what role you find that they have.
Great question.
Thank you so much for that question. I'll tackle maybe part of the alcohol question, and I think it's very true, especially since our COVID times. We're certainly finding in clinical practice that the true rate, and we may not even know what that true rate is, but the reported rate of alcohol use is quite high, with many women, drinking every day a glass 2 or 3 of wine, typically to kind of relax and wind down. This happens because of what sort of life throws our way, but also because there is a certain element of increased anxiety with the time of perimenopause and menopause. This is a time where we're often taking care of families, taking care of our aging parents, where we have a lot of work demands on us, and alcohol is one of the tools that women use. In reality, alcohol does not have a lot of biological benefits, and it's not really great for us, including increased risk of breast cancer, since we're sitting here, including the calories and amount of sugar that is in it, including the effect of sleep, something that a lot of women in perimenopause and menopause complain about. In fact, sometimes even as little as 1 glass can change the architecture of sleep. So rather than prescribing medications or suggesting something in a bottle that someone can take, one of my initial recommendations is often to significantly reduce or completely abandon the use of alcohol, and so many people feel so much better right away from that.
And Dr. McCann, give us guidelines like, healthy range, et cetera. Asking for a friend. Yes, no, just kidding. Asking for a friend. No,
My answer depends on whether my wife's present or not when I give these talks. So up until about 4 years ago, the recommendations for alcohol would be no more than 2 servings a day for men, no more than 1 serving a day for women. I had chaired a guideline a few decades ago where we actually came out officially and said that no alcohol, because there are adverse effects of alcohol unrelated to the biology, which is motor vehicle accidents primarily, but also depression, absenteeism from jobs, marital issues, et cetera. What happened 3-4 years ago was the Global Burden of Disease Group in the United Kingdom in Lancet published the results of a worldwide study looking at populations to answer the question, what is the most amount of alcohol a human being of any ethno-cultural population, what's the you already see where this is going. What's the most amount of alcohol that a human being can consume without any adverse effect? Adverse effect being a longitudinal, in the future risk for a chronic disease, et cetera. And the answer was 0. So the conclusion was there is no amount of alcohol that's safe for a human being. Let's answer the question 3 ways. The first way is epidemiology, which are these associations. When you look at these populations and you look at alcohol consumptions or dietary patterns, they're inversely related to the consumption of, remember I said fresh fruits and vegetables, 5 to 7 servings a day or 7 to 10. So the fresh fruit and vegetable intake goes down, alcohol goes up. You see it for head and neck cancer, you see it for lots of other types of cancer. Mechanistically, here's how it pans out. So the human being has no ability to burn off alcohol to heat. So if you're running the marathon and you're downing a goop or you're downing a chocolate bar or a donut, you're going to burn it off for energy and you're going to have it while you're running or exercising. If you're running a marathon, if you're starving and you drink alcohol, your body's going to convert the alcohol molecule into fatty acids and fat. And that fat actually deposits in parts of the body which are not necessarily natural or their first choice. They become more inflammatory fat depot, and it leads to insulin resistance. And that's the mechanism, the pathophysiology where these unhealthy diets lead to cancer. So with insulin resistance, the insulin that's produced by the pancreas isn't working so hard, so insulin goes up. With the higher levels of insulin, it's binding to insulin receptors, but it's also binding to other cellular growth promoting receptors, and it stimulates growth of cells and stimulates growth of cancer cells. And that's why statistically you see these increased risks of cancer with insulin resistance and diabetes, particularly, and obesity, and they're all related. The other issue that you brought up was the cosmetics or cosmeceuticals, or however you want to capture this. And this falls within the category of endocrine disrupting compounds. So who here has ever had bubble tea? Right? Who's had bubble tea? You've had bubble tea, right? You don't have to go to Malaysia to have bubble tea. You can just go down to Chinatown or Madison Avenue. They're advertising for it. So bubble tea it's like a tapioca type stuff that's in there, but they put something in that's a plasticizer. So it has the mouth feel that feels great. It's velvety, right? It has that mouth feel. Well, that plasticizer is diethyl hexyl phthalate. It's kind of related to bisphenol A. These are endocrine disruptors. These interact with molecules on your cells, fat cells, and they cause adiposity, obesity, diabetes, insulin resistance, atherosclerosis, and I can keep going on and on. And these types of chemicals have fully contaminated our food supply. This is actually a big political issue. So when you look at our water in the country and you look at our food supply, it is contaminated now by not only waste, but by these endocrine disrupting compounds. So if you're into the whole environmental impact and the role in breast cancer, this is something to look into for action.
Wonderful. Next question, I see one in the back. And let's ask the panelists so we can get to as many as we can to keep answers to a minute or two. Yes.
So I have lymphedema. I'm a survivor, 22 years. What are you doing at this moment to limit people from getting lymphedema? Is my first question. And I'm also a BRCA too, so I want to know what type of trials I need to go through to basically, for anybody, because understand, as I understand Dr. Smith said, there's not many of us African-American women who go through clinical trials for who actually have the genetics thing. So what do I need to do to be a part of that trial?
Excellent. So I'm going to turn it to Dr. Anderson to answer. As a surgeon, we're probably the ones who most address and most see the lymphedema. And I'm happy to weigh in on that as well. And then perhaps Dr. Sperano and Dr. Smith can talk about the clinical trials as it relates to the BRCA genes, which there's some really exciting things going on. So I'm glad you asked.
So first off, for those who don't know, lymphedema is basically swelling of the upper extremity on the side that you may have had breast cancer treatment. And this can be a chronic condition that could be lifelong. So the main thing that we're doing to decrease the rates of lymphedema is actually to de-escalate the amount of surgery that we're doing. So we've already talked about how we've de-escalated the amount of chemotherapy we're needing to do, as well as keeping the outcomes better. We're doing the same thing from the surgical side. So we've realized through clinical trials and through research that we don't need to do bigger surgery on the lymph nodes, which can lead to lymphedema, with the same outcomes. And a lot of times people can get radiation and other things that have a lower risk of lymphedema than surgery does. So that's the primary thing that we're doing. And lymphedema rates have decreased significantly with the advent of this de-escalation of surgical care. So that's the primary thing that we're doing. For those who have lymphedema, seeing physical therapy specialists who this is what they do and see, who specialize in fitting sleeves, doing basically massage to minimize the amount of lymphedema, getting these women in to see these specialists even before the surgery or after is really monumental in terms of preventing worsening lymphedema, as well as to educate women on how to handle this in a chronic fashion.
Dr. Smith, Dr. Sperano, talk about BRCA gene and clinical trials and the exciting new drugs that we have to offer.
Sure. Well, I have something better to offer than a clinical trial, and that is a drug that's now approved on the basis of a clinical trial. That the drug is called olaparib. It's approved initially, it's been approved for a few years, initially to exploit the Achilles heel of cancer cells that arise in people who have alterations or variations in the BRCA gene that puts them at increased risk of developing cancer in the first place. It turns out that the cancer cells also have that altered BRCA gene that makes them susceptible to targeting one specific DNA repair pathway. And when you use a drug that can block that pathway, you induce what's called synthetic lethality in the cancer cells, but not in the normal cells. And so this drug was initially approved for patients who had advanced forms of breast cancer associated with the germline BRCA alteration. But now, on the basis of a large clinical trial, it was just approved by the FDA for the treatment of early stage breast cancer in women at high risk for recurrence, where it reduces the risk of recurrence by about 40%. It would need to be given within about a year of the diagnosis, and it's only been shown to be beneficial at those who are at the highest risk. But it's a very useful new treatment for women who have both BRCA1 and BRCA2 variants.
Question in the corner, Edward.
Continuing on the BRCA question, for someone who had a BRCA test 10 years ago when this initially started, would you recommend another BRCA test, which is 10 years today, more advanced and more analytical than what was done 10 years ago, or would you rely on just that diagnosis from 10 years ago?
I think what you're asking, which is a wonderful question, which is, what more have we discovered about genetics as relates to breast cancer? For sure, those tests from 10 years ago or 20 years ago are absolutely outdated, and I'm going to ask Dr. Anderson to take this because we are telling our patients who were tested for any kind of genetic, so before 2010, 2013, we were only testing for BRCA. And now we have a whole panel of other genes that we know about and are also actionable. And that's been a huge area of progress. So do you want to talk, David, about what we're testing for now and how we update these tests?
Yeah, so it's a great point. And so as we've learned more and as we've gathered data, so these genetic mutations have been basically banked in a data set. And so as we progress and we're learning more and more and we get more patients enrolled, we're finding more and more about these genes and if they actually predispose women and men to breast cancer. So we have much more comprehensive genetic testing than we did prior to 2013, which, as Dr. Port mentioned, we were doing primarily BRCA1 and BRCA2. There are now additional genes. The most common now that you hear about the most is PALB2. This is basically kind of the second generation BRCA, which we know confers a relatively high risk of developing breast cancer, sometimes upwards of 40% lifetime risk of developing breast cancer. There are other mutations such as what we call CHEK2 and the ATM gene. These are all things that we currently now test for that increase a person's risk of developing breast cancer. Now, the data is ongoing, and a lot of these genetic mutations, how high your risk is, also has to do with what the family history is as well. So there's something called penetrance. So if you have this mutation, it actually causes things like cancer, breast cancer, ovarian cancer. That's penetrance. Some of them aren't as penetrant as others. So if there's a lot of family history and you also have that gene, then you're kind of the highest range within that risk model of that gene. So there's a lot more we're testing for, and I routinely tell patients if they've had genetic testing prior to 2013, it should be updated at this point.
Yes, quick. So many questions from this side of the room. Nobody over here? Nobody? Nobody? Yes.
Hi. Again, thank you for doing this panel. It's very informative. For those of us who've been either on an aromatase inhibitor or tamoxifen, in my case, now that you're getting to a point where you're going to be off it, is there all of a sudden an increased risk of recurrence? I mean, because I'm kind of getting to that point and I'm saying, maybe I don't ever want to be off it, which of course is ridiculous.
It's such a good question, Patty, because a lot of people feel like these medications, you know, what we say is they have their surgery and some have chemo, some don't, and they're on this medication. It's a little bit like a security blanket. And while it can be a painful reminder for women on the medication every single day of this past, it can also feel like they're doing something every day to prevent their breast cancer from coming back. And a lot of data has been generated about the optimal length of time and so forth. And I'll defer to Dr. Sperano, who really, this is what he does in terms of these decisions on an individual basis.
The average duration ranges anywhere from 5 years for people who are at very low risk, which would be node-negative tumors up to 2 centimeters, estrogen receptor positive, to as long as 10 years. We have data out to 10 years. We don't have longer durations of therapy. We do know that for certain types of breast cancer, especially the estrogen receptor positive, HER2 negative types, that there is this continuous risk of relapse that can be present for many years after the diagnosis, and that the higher your risk factors, the more advanced disease at presentation can be associated with that risk down the line. What we don't have yet is proof that intervening with more than 10 years of therapy is going to be beneficial. Having said that, I do have some patients in my practice who, you know, we get to the 10-year point and we look at the potential benefits and risks, and sometimes we make a mutual decision to continue. What's changing is we have better diagnostics. I talked to you about how diagnostics can really help you guide the initial treatment choice at the time of the diagnosis. Well, we now have blood tests that can evaluate for circulating tumor cells in the blood that could otherwise not be detected by routine blood tests, or by looking for minute quantities of DNA in the bloodstream. And there are tests available. I'll give you one example of a study that I was involved with where we took women who were 5 years after the diagnosis without any clinical evidence of recurrence, and we assessed a sample of blood for the presence of circulating tumor cells in a blinded fashion. We just continued to follow them. We found that only 5% of women had circulating tumor cells in their blood 5 years later when they otherwise were ostensibly cancer-free, but they did have a 13-fold higher risk of recurrence than women who were CTC negative. And by 2 years, the positive predictive value was about 30%. In other words, 30% of that 5% who had the positive test did have a recurrence. And, but what we haven't been able to do yet is take the next step, is to be able to integrate these tests into our decision-making process down the line. Those studies are ongoing right now, and I think in 5 years we'll be in a position we'll be able to use those tests to make more informed decisions about what to do 5, 10, 15 years down the line, just like we're able to do at the time of diagnosis.
Yeah, so this work is changing all the time, and these newer tests, and what's really interesting is that advances in technology and biotech have also fueled these tools that we'll have. And we have more to offer every year, which makes the field so optimistic, and we have the fact that we have so much to offer. There's a question in the back there. Yes?
Hi, yes.
Hi.
My question is for you, Dr. Port. I am kind of a new patient at the Dubin Center. I just had my surgery, and I'm headed into medical oncology soon with Dr. Tiersten. Dr. Anderson's team gave me your book, which I really loved and was extremely reassuring for me. I'm HER2 positive, so the information you had on there made me feel a lot more comfortable with that diagnosis about the new developments. My question for you in general is, I know your book was published in 2015. Is there anything in particular, and we've talked a lot about people have had such good questions and you've made a lot of comments. If you could choose one or two major things, if you could republish it today, what would you include?
It's so sweet of you. Thank you so much for that, for that shout out for the book. What's, so kind of you and I just, I'm so happy that it's helped people in their path. I think so many of the developments, particularly what Dr. Sperano talked about, are true, which is we're getting more and more precise and personalized in our care. So I think I touched on the book in 2015. We were just starting to use Oncotype clinically. And now we've moved past that, where it used to be Oncotype testing for chemo or no chemo was just for women with negative nodes. And it's really been in the past 5 to 7 years now that we're also using Oncotype in populations with 1 to 3 positive nodes. So those are the boundaries, I think, of the treatment options that I think have mostly changed. We're doing way more nipple-sparing mastectomies than we were ever before from a technique standpoint. But everything else in terms of kind of the overview, I think, is really, really still the same. The only other thing I would say is one of the big areas which no one has asked about, but we can talk about a little, is the area of DCIS, which is non-invasive, what we call stage 0 breast cancer. There are huge strides being made in this area to also stratify people based on risk. And we have an ongoing trial at the Dubin Breast Center, which is part of a national trial that's called the COMET trial for, believe it or not, there are cases of DCIS where there is the idea that they may be overdiagnosis and overtreated and may be just the kind of thing that percolates along for 20, 30, 40 years. And so even in the area of the earliest cancers like DCS, we're pushing the envelope and offering, believe it or not, as part of a clinical trial, which is the only way you learn anything in terms of safety, of whether or not we can offer observation only to some women with DCIS. And so I think those are the things, the areas of really robust and fertile research that have changed, which we're so proud of and which we're working on every day. I think we have 20 clinical trials at any given moment opened at the Dubin Breast Center, which is really a huge source of pride in terms of our patient participation and pushing the envelope forward for the next generation. So that we do have new things to talk about on the panel every year. Other questions?
First of all, as a friend and as a person too, I would like to thank everybody in this room as a patient, because it's a true honor to be a patient. My question going on is, with all these changes that are happening with looking at genetics and looking at what we can do to treat, and looking at all of you beautiful young women who are here today who may not have been here 20 years ago. Should we be pushing our daughters and our nieces and our nephews too, earlier than what was recommended if we can get them to get observation, given that X-ray and different kinds of medical imaging is not as dangerous as it was in our parents' generation if you don't do it. So the guideline's at 40, but should we say, my daughter, her mother had it, not related, should my daughter be starting at 35? I mean, nobody talks about what we do.
Perfect. This is such an important question because it really applies to pretty much everyone in the room who has family and offspring and people that they care about. And the question is, what are the current recommendations for screening for breast cancer, both in the general population and for someone with a family history? And I'm going to ask my colleague, Dr. Anderson, who deals with this every day.
So the general guideline for the general population, so those at average risk, is to start annual mammography, so screening mammography at age 40, and continue on an annual basis thereafter. So that's the general recommendation. Now, for those who may be at a higher risk, whether it's due to a family history, certain pathology that they've had on biopsies of the breast, things like that, we take into consideration, estrogen exposure, personal factors that can increase risk. Those who are at higher risk may need to be screened earlier. So in terms of family history, if you have a first-degree relative who had breast cancer at a young age, so what if your mom or your sister was diagnosed in her 30s or 40s? When should you start screening? And it's typically 10 years before that age at diagnosis. So say you were diagnosed at 45, your daughter should start her screening at age 35. That's the recommendation for women at higher risk. Now, there are women who have genetic predisposition, so BRCA genes. So if you don't have that, then that's the recommendation. But if you do, then we may start screening as early as age 25 in those genetic carriers. And that can include a combination of mammography, but primarily also breast MRI as a screening tool we use in women who are at high risk. Your sons, yes. Good.
We can't leave them out.
So it's those who have a genetic predisposition and those who don't. So in those who don't, really the lifetime risk is not significantly elevated. So they do not need to be screened from a breast cancer perspective in terms of mammography or anything like that. But in those who do have a BRCA mutation, there's conflicting data, but they do need to be followed at a high-risk center because their risk, say if you're a BRCA1 or even a BRCA2 carrier, which is more common in men who have male breast cancer, their risk of developing breast cancer is actually that of the general population of women. So if women are getting screened, then they also should be screened as well, okay? And basically, it depends upon the age, but we start screening at age 30, and later, you wouldn't do it in the 20s for male.
Yeah, I would completely agree. And what I would say is what's really interesting is the BRCA1 mutation for men is associated about a 1 or 2% risk of breast cancer. For men, it sounds really low, except if they don't have the BRCA gene, male breast cancer is like 0.001%. So there's only about 2,500 or 3,000 cases of male breast cancer in this country per year. We happen to see a lot of it because we are a specialized center. If you have the BRCA2 gene and you're a man, your risk of getting breast cancer is about 7 to 10%. And the reverse is also true. If you're a man with breast cancer, of course, we test all of them for the genes, and about 10% will find a genetic mutation. So, other questions?
So should everybody be tested for the BRCA gene even if it's not in the family?
Great question. Let me throw in my 2 cents for this. I think that genetic testing is vastly underutilized. I do think knowledge is power, and I think you have to be prepared to understand what that knowledge is, and there's lots of different options. It's not you test positive for a gene, go directly to OR for bilateral mastectomy. People have to know they have options for everything. And there are certain groups ethnically that are at higher risk for having a BRCA gene. For example, in the general population, about 1 in 500 to 1 in 1,000 will have a BRCA gene. So it's far less than 1%. Among the Ashkenazi Jewish population, okay, these are Jewish people from European descent, it's 1 in 40. So 2% of the Ashkenazi Jewish population has the BRCA gene. And so there are many of us who feel that population-based testing should be done in these selected groups where the yield is higher. Keep in mind, no ethnic group is exonerated. There's an Icelandic version of BRCA. There's a Hispanic version of BRCA. We see BRCA in Black women. This young woman shared her story. We have a lot of BRCA across all ethnic backgrounds, and it's just a question of picking populations where the yield is the highest. In our society, the American Society of Breast Surgeons came out with a recommendation about 3 or 4 years ago recommending offering or testing in every woman diagnosed with breast cancer, regardless of their family history, regardless of their background. And the one thing that I'll also say is that we implemented a program. We were worried that we weren't able to offer BRCA testing widely enough. So we put together a program with a company where every single woman can get BRCA testing, or genetic testing, I should say, the wider panel, regardless of ability to pay. And that is one of the hugest things we've done in the last 5 years, working with a company. The maximum out-of-pocket expense is $99, which will be waived if you can prove financial need. So all of our patients who are uninsured or who can't pay have their fee waived, and we can offer genetic testing regardless of ability to pay. Other questions? David, you want to take this, or Joe?
That's a population-based question, and I'm not going to be able to answer it for all ethnic groups. But for the Ashkenazi Jewish population, it basically has to do with, birth rates and things like that, and how the genetics is staying within a population. So then, if you have what we call like a genetic bottleneck, so you have a larger population which is now smaller, and there's not a lot of marriage or things like that outside of the population, then you're going to see more of these mutations basically propagating throughout the generation. So that's how you can get these higher risks of these mutations in certain populations. For like the African American community and things like that, I don't know, Cardi, you could maybe.
Do you want to talk about genetics, Cardi, in African American population or people of color, and how we see that manifested?
Sure, I can speak to a little bit. Joe can probably pick up where I leave off. I think part of what I mentioned before is, a reason why the BRCA story became known predominantly first in the Ashkenazi Jewish population is because there were more of them who were getting this test done, and we saw more of it. When we talk about clinical trials, so less than 5% of all patients enrolled in clinical trials identify as people of color, so as Black and or Hispanic. So when we think about rolling out these new kind of technologies and tests, those populations just aren't as well represented. So although we do tests and we're able to see them in women of color, we also don't know what some of those tests mean because we haven't done enough testing to understand the longer-term significance of it.
Yeah, and I would just add to what Dr. Smith said that, addressing what the Dubin Breast Center does in terms of providing one level of care, irrespective of someone's background or ability to pay, is the single most important factor in terms of addressing disparities. So it's necessary, but it may not be sufficient. So I'll give you two examples where it may not be sufficient. Number one, we know from some of the research that I've been involved with that Black women have twofold higher rates of neuropathy related to a chemotherapy that's commonly used in early breast cancer. Neuropathy being a situation where people can get numbness and tingling and even pain in the hands and feet, which often, hopefully, is temporary, but sometimes can be long-lasting and debilitating. We found that Black women were twofold more likely to get it and more likely to have the more severe and intractable forms. So in collaboration with another group from Indiana University, we identified some genetic variants specific to Black women that are associated with this higher risk of neuropathy, and we conducted a trial specifically in Black women that was done throughout the United States to prospectively validate these genetic variants, with the notion being that if we validate it and prove this to be correct, then we may be able to use this test to guide a specific type of taxane therapy, this type of chemotherapy that causes this, or completely avoid that. So that's one example. The second example is that we found in our research in now 4 different data sets, including 3 clinical trials data sets and 1 hospital-based data set, that Black women with estrogen receptor positive, HER2 negative breast cancer have higher rates of recurrence. And it's not due to differences in access to care, their compliance with chemotherapy or endocrine therapy, and it wasn't explained by social determinants of health. And in fact, we found in one of the studies that Black women were actually more compliant with endocrine therapy than other races. So there's clearly, there are factors that we don't understand that are contributing to these disparities. But again, addressing the social determinants of health is necessary, but there's still other work that we need to do to try and uncover some of these other disparities.
Last question. Maybe.
Thank you. Thank you so much for the excellent work that you do. We truly need you. So thank you for what you do. I am a 2-time breast cancer survivor, diagnosed 21 years ago at the age of 34, and then recurrence 15 years ago with metastatic. Can you talk about the rates that are being done in the realm of treatment to metastatic and how it is helping patients to live longer? Because I'm living 15 years with metastatic, and I think that's, thank you. And I think I believe that is done because of the great strides and the work that is being done as it relates to metastatic. So can you talk a little bit about that?
Sure. I think Dr. Sperano is the singular best person to talk about this. And thank you for your question, because you're so right that we have made strides across all fronts, and in this front in particular.
So the good news is there have been about at least a half a dozen new drugs approved over the last 5 or so years for all types of breast cancer. The HER2 positive type of breast cancer, there are multiple new drugs, including drugs like pertuzumab, which binds to the HER2 receptor and prevents HER2 molecules from speaking with each other and increasing their signaling through the HER2 pathway. There are antibody drug conjugates. In other words, a Herceptin molecule that's coupled with a toxic payload, chemotherapy payload that delivers the chemotherapy drug directly to the cancer cells, which has now been shown to be effective not only in HER2 positive or HER2 overexpressing cancers, which is about 25%, but also about the 50% of patients who have HER2 low breast cancers. You may actually, I predict you'll be hearing about it over the weekend, because there's going to be, our oncology meeting is over the weekend. The data are going to be presented on Sunday, showing a benefit from a new drug that was initially approved for HER2 positive and now has been shown to improve survival for HER2 low. There are the CDK4/6 inhibitors in estrogen receptor positive breast cancer. There's 3 of them now approved for advanced stages of disease. At least one of them has been shown to prolong survival. In that context, one of them is now approved in early stage breast cancer. And there are drugs that are approved for triple negative breast cancer, including immunotherapy in both advanced and early stages of breast cancer, and also antibody drug conjugates for triple negative breast cancer. So I think we're just beginning to scratch the surface of what's possible. And I think you're living proof of what's possible.
So on that optimistic note, we will not stop until every case of breast cancer is treated, cured. And that is our life's work. That is our mission. That is what we're all here to do. Let me cut off questions there. I cannot tell you all how much we appreciate the support given here on a day like today to come to support us and so forth. We really, what you have done is helped every woman who walks through the doors of the Dubin Breast Center get the highest possible caliber of care that is in the world at this point. And we're committed to offering that care. And it's not just, it's really not just excellent care, it's really exceptional care for all women, as you heard, regardless of their ability to pay. And it can't happen without support. If you are so inclined to contribute, there are donation cards at the table. We're really appreciative of all of you just being here. It was so wonderful to see so many new faces. I want to thank my extraordinary panelists, Dr. Anderson, Dr. Barbieri, Dr. Mechanic, Dr. Smith, Dr. Sperano. Each one of these people is a secret weapon that I use and pull out at any given moment to address the concerns of our patients. And I hope you all learned a lot from them. I hope you take this knowledge and share it with those around. Again, we're so appreciative of your support. I want to wish every single one of you all a happy and healthy summer.